Hi, everyone. We just wanted to welcome you guys. We'll get started here in a couple minutes. The Midwest Vascular Surgery Society doing the VSIG case presentations. We've got 4 for you tonight from Henry Ford, Indiana University, Medical College of Wisconsin, and WashU. And we'll have a few announcements at the end. My name's Ashley Gutwein. I'm from Indiana University, and we are going to start with Sayed Kairon from Henry Ford, and he's going to be presenting a case over endovascular repairs of type A aortic dissections.
Can you guys see my screen?
Yeah.
Hello, everyone. My name is Saeed Parwan. I'm a first-year vascular surgery fellow here at Henry Ford in Detroit, Michigan. Thank you for the opportunity to share an interesting case with you all. The topic of my case is an endovascular repair of acute type A dissection with a zone 0 thoracic branch endoprosthesis and a left subclavian artery stenting. I know it's a mouthful, but I will go over it in details. This was a 80-year-old man presented with shortness of breath and altered mental status. Patient had a recent admission for COVID-19 2 weeks prior. Past medical history consisted of Parkinson's disease, atrial fibrillation, and hypertension. He also had a history of a pacemaker for sick-sinus syndrome and was a former smoker. On workup for his shortness of breath, we performed a CT scan, which showed a type A aortic dissection starting in his ascending aorta, which we see here. It's kind of extended downwards. I will go over it in details. But basically, aortic dissection is when you have a tear in your aorta, which in most cases can be caused by really high blood pressures. And blood finds its way between the layers of the wall. You can see it here. And through this tear, and this separates the different layers of the arterial wall and causes further problems. We have 2 types of aortic dissections. One is type A, which you see over here, where the entity is in the first part of the aorta called the ascending aorta. And then the second type is type B, which is when the entity is just past the left subclavian artery origin, which is over here. Classic teaching is that when you have the 2 types of dissection is when type A dissection is a true surgical emergency because it can cause problems with your heart valves. You can dissect into your coronary arteries and that feeds your heart, and then it can also end up in ruptures. These are typically managed with open surgery. While type B dissections are managed medically with antihypertensive medications. This CT scan shows you that his, which I will have let it run through, but basically shows that his entry tear is in his first part of his aorta, which you will see shortly. And then, and it pretty much involves his entire aorta in his chest. So so this is the aorta, you see, this is the ascending aorta over here. And you can see the entry tear over here. And it kind of goes down, causes a really bad reaction over here. You can see some blood outside of the area over here. You're still in the chest here. You see all of this stuff there. So when he presented, the cardiac surgeons didn't think that he was a good surgical candidate for open surgery. So the question is, what are we supposed to do here now? The options were, according to them, they didn't want to offer him an open surgery, so it was either do a hybrid repair, which I will touch upon, or do nothing. So we offered this to the patient, and he decided to do with a hybrid repair. So we really had to be creative here in terms of the hybrid repair. So they contacted the vascular surgeons here at our hospital, and we offered him a staged hybrid repair. So in terms of the aorta itself, the aorta is divided into zones. You can see here, zone 1 starts in the ascending aorta and then it kind of goes down all the way down to zone 11, actually, the common iliac arteries. But his dissection involved zone 0, and in order to fix his dissection, we would have to cover his N2 tear with a stent. And in order to make sure you have perfusion to the vessels, you really have to you have to, if you're gonna put your stent in here, you have to make some type of a debranching procedure or some type of a laser fenestration, which I will go over in my next slide here. But basically, one of the new things that was recently approved was a stent by the Gore company, which is called the Gore thoracic branch endoprosthesis, which is a stent which has this side branch. It's typically used for the left avian artery, but we repurposed the role of this stent and decided to use it in a different part of the zone 0. So the two options that you have when you do a hybrid approach is either you do a cervical debranching procedure, which is when you connect, basically you hook up the left carotid and the left subclavian to the right carotid, which you can see here. So left subclavian, left carotid to the left, to the right. Then and then the other options is that you do a left carotid subclavian bypass, and then you make a hole in the graft, and you, in order to provide blood flow to your brain, to the left side of your brain, you want to make sure that you have blood flow to your arm. So that's basically what we kind of offered him. We staged his repair. We initially managed him with the blood pressure medicines, and you can see here during the first 2 days. And then we first performed the left carotid subclavian bypass using a prosthetic graft. And you can see here after his after his carotid subclavian bypass, on a CT scan here, which we did for preoperative planning for his next repair, the next stage of his repair. This was the second stage of his repair. We first got access to his arteries in his groins. We put wires up and we took pictures of his aorta to kind of get a lay of the land. And so we started our stenting process. We basically started stenting distally, it's lower part of his aorta in his chest, and we kind of built that upwards. You can see the stents being here, and we kind of built it upwards like that. In order for us to be able to deploy our grafts, we have to get access to both of these upper extremities.
1 second.
On the right
Stop.
side, you can see that we stented into his. We had to. This was the thoracic branch endoprosthesis. In order to get that, you have to have right upper extremity access, and then for in terms of the left upper extremity, you had to have access in order to be. So we can do a laser fenestration from our stent. And then what that basically means is that you make a hole using a laser device, and then you put a bunch of wires, and then you balloon your hole, and then eventually you gotta put a stent up there. So the left arm can get blood flow, and then your brain is gonna get blood flow through your left arm and through your bypass. And you can see here how we've deployed this branch graft into for the right side, and here you can see the branch into the left side. And these were our final shots, making sure we didn't have any leaks around our stents. And you can see how nicely it fills over here. This is the heart. We are really close to the heart here, and we basically were able to see blood flow going into the right upper extremity over here, towards the right brain, and also the left upper extremity and towards the left brain. And this is to make sure that we have blood flow going to the intestines and to the guts. We place our stents above that. And yeah, in terms of his post-operative care, it was complicated by a minor stroke and a pneumonia, which he initially recovered from and was discharged to a rehab facility. Very interesting case. We vascular surgeons do some very interesting and cool cases. So if you have any questions about this case, I'd be happy to take them now. And thank you for allowing me to present.
Thank you, Saeed. That was a nice presentation, and just for the medical students that are on board, type A dissections is a lethal disease. About 80%, about 95% of patients with type A dissection die, 50% within the first 48 hours. There are new grafts coming out that it's an open operation that we usually fix using cardiopulmonary bypass, and cardiac surgery usually does it. But with the advancement of endografts, we are coming up with new solutions to treat these type A dissections using endografts. I think this case just emphasizes that vascular surgery uh, has a lot of new technology coming up. We're finding new ways to treat diseases that people found very difficult to treat before. And it highlights the technical skills you get as an endovascular surgeon in terms of trying to fix these complex diseases. So I think this is kind of what it reflects. We're going to go on to the next presentation. Next presentation will be Jack Sanson from Indiana University. He's going to talk about a rupture from a type 1 endoleak that underwent an emergent physician-modified endograft. Jack?
Right. Thank you for the introduction. I'll share my screen now.
Yeah, do you want to introduce yourself?
Yep. So I'm Jack. Here, let me pull up the PowerPoint mode. Okay. Is everything okay?
Yeah, beautiful.
Okay. My name is Jack Sansone. I'm a fourth-year medical student at Indiana University, planning on applying to integrated vascular programs. I will be discussing a ruptured aortic aneurysm from a type 1A endoleak today. Special acknowledgements to IUSM faculty and residents in helping me finalize this PowerPoint, and thank you to MVSS for this opportunity. Just an overview of my presentation. I'll be discussing the case. It's a case of Dr. Fajardo's. I'll be discussing endoleaks, general concepts in managing ruptured AAAs, and then specifically talking about ruptured juxtarenal AAAs. Below, I present a term key of abbreviations that I'll commonly use in this PowerPoint, and I'll make sure to talk over them so we're all on the same page. So the case is a 79-year-old male with known AAA status post remote elective repair with infrarenal endovascular aortic repair that was lost to follow-up. He presents to his local outside hospital for 1 hour of lower back pain, and CT angiography of his abdomen showed type 1A endoleak, new retroperitoneal hematoma, and enlargement of his aneurysm. Other medical history is shown below. Here's a video of his CT angiography on presentation. And here, as we descend into the abdomen, we can see retroperitoneal hematoma, his old EVAR, and then his aneurysm. The next slide will help kind of discuss this imaging further. So here I took a screenshot of an important part of that last CT scan. I've labeled A here. You can see now we're in the abdomen. You can see labeled A, his old EVAR. This is the proximal portion of the EVAR. You can see it's not well adhered to the native aorta wall, concerning for type 1A endoleak. And B, just redemonstrating the retroperitoneal hematoma, putting everything together, diagnosed with his rupture, and he was emergently transferred to our hospital for further management. Upon arrival, he was stable and he was consented for fenestrated endovascular aortic repair by physician-modified endograft, and he was taken to the OR. He received a 4-vessel FEVAR with stenting under local anesthesia. Postoperatively, he did well and was discharged post-op day 5. And just on this slide, I want to highlight that this case was done under local anesthesia. You can imagine these patients are coming in emergently, undergoing hemorrhagic shock. These patients are really relying on their sympathetics to, clamp down their vessels to compensate for this shock. And we know that, using general anesthesia causes vasodilation and could cause patients undergoing a procedure to lose their ability to compensate for their hemorrhagic shock. Doing a case like this with an endovascular approach and being able to use local anesthesia is an advantage. So this is a post-intervention angiography that was performed. you can see his completed fenestrated repair with patent bilateral renals and SMA, and no evidence of endoleak. Here on this slide, I discussed the complete repair that this patient has or had, as well as I show an actual image of what a fenestrated endovascular graft looks like. So just so everyone, we're all on the same page. These patients are coming in emergently, or this patient came in emergently. And the fenestrations for this case, for this endograft was done in the OR. And so the surgeon who was doing this case, Dr. Fajardo, had to treat the fenestrations based off of the patient's CT scan. So we had to modify the endograft accordingly. And these fenestrations have to be very specific to the patient's anatomy. If you can imagine, the fenestrations when the actual stent graft is deployed have to line up appropriately with the branches of the aorta to maintain perfusion. So actually, a couple of days after the procedure, the patient had a repeat CT angiography. So I will just play that. As we descend into the aorta, you can see his fenestrated graft with stented SMA and bilateral renals, which were patent. And now I would like to bring our attention to a discussion about endoleaks. Endoleaks are a common complication of endovascular aortic repair, either during the procedure or long-term after the procedure. Going into type 1 endoleak, this is an issue with attachment site. A type 1A endoleak is an issue with the proximal attachment site, like the patient in our case. As you can imagine, blood is continuing to flow down into the aorta, but is leaking into the aneurysm sac proximally. This is more of a pressurized flow compared to a type 1B endoleak, which is a distal attachment site issue, where retrograde flow is returning into the aneurysm sac, causing it to increase. A type 2 endoleak is the most common type of endoleak. It's caused by retrograde bleeds from lumbar vessels. A type 2A endoleak is caused by one vessel versus type 2B, which is from multiple. And a type 3 endoleak is caused by graft defects. These endovascular repairs are often done with multiple grafts. A type 3A endoleak is when you have loss of junction between grafts. A type 3B endoleak is caused by a tear within the endograft itself. A type 4 endoleak is when blood seeps through the pores of an endograft and causing the aneurysm sac to increase in size. A type 5 endoleak, we call it endotension. Basically, we know the aneurysm sac is increasing in size on imaging, but we can't attribute another type of endoleak as the cause of the increase in size. So now jumping to management of ruptured AAAs. And on this slide, I have 4 kind of concepts that I use to conceptualize management of ruptured AAAs. And I have them overlapping because, like a lot of things in medicine, decision-making isn't always black and white. There's a lot of gray areas. And so I'll just go into it. Talking about time. Time is very important. As you can imagine, these patients are coming in emergently. Their abdominal aorta has ruptured. As the surgeon, you don't have a lot of time to prepare for the case. And then in doing the case, you have to be very efficient. When I think of anatomy, I showed the diagram of anatomy of AAAs. Basically, if you can imagine, the higher that the aneurysm ascends, the more branches of the aorta that are involved, and therefore a more complex repair would be required. When I think of patient selection, I think of how sick the patient is, how frail the patient is, comorbidities, and likelihood of having a good outcome after like an open repair versus endovascular repair, which going into open versus endo, when I think of open, I think of a big midline abdominal laparotomy exposure or retroperitoneal exposure, getting into the aneurysm and manually getting proximal and distal control of the aneurysm, controlling the bleed, getting into the aneurysm and sewing your bypass graft to healthy aorta arterial tissue. And when I think of endovascular, I think of minimally invasive approach. But I think anatomy is very important. And I'll bring your attention to, infrarenal versus juxtarenal. With infrarenal, you have good healthy aortic tissue distal to the renal arteries, you have a good landing zone for the proximal portion of a stent graft. Versus a juxtarenal, you don't really have that healthy landing zone below the renals. You'd have to stent covering the renals or the SMA or the celiac, which is why you would need a fenestrated graft approach for a juxtarenal AAA. And again, everything ties back to time. The case that I presented, the physician modified endograft, you have to, again, you're modifying the graft in the OR based off the patient's CT scan. This takes a lot of time as well. So now going into juxtarenal ruptured AAAs, the options are open versus an endovascular approach. Open is traditionally more common. Again, the big is a big open surgery. You're quickly getting good manual control of the bleed, but higher morbidity and mortality associated with the procedure and complications afterwards. When I think about the endovascular approach, obviously more of a minimally invasive procedure, but is shorter postoperative courses, decrease the risk of complications. But this is a very complex endovascular approach. There's not many institutions in the U.S. where a physician modified endograft for a ruptured juxtarenal would be performed. You need a minimal anatomy. You need to know the anatomy well. You need a specialized center with a surgeon who's skilled in doing and has practiced with physician modified grafts. And then here in the figure, I show a picture of one of these fenestrated grafts being performed and the fenestrations prior to being stented. So here's the resources for what I used to make this presentation. And I would like to open the floor to questions if anyone has any.
Jack, that was really, really nicely done. So this guy had an endograft placed, and he had a type 1A endoleak, which is a leak from the proximal end of the endograft. Do you think if he had an open repair, he would have had the same problem? And what do you think if somebody has an endograft, what does this case teach you in terms of follow-up with patients that do have an endograft placed?
First off, thank you so much for your question. To talk about your first question, actually, could you repeat the first question?
So do you think if he had an open repair, do you think he would have had this problem initially? Do open repairs
he wouldn't necessarily have an endoleak because you're with an open repair, you're sewing the bypass graft to healthy aortic tissue. So not really, you wouldn't have an endoleak like this patient had complication after his first infrarenal EVAR. Yeah. And can you remind me your second question again?
And somebody who has an endograft, an endo stent, like he had an EVAR, this complication, what does it teach us in terms of the follow-up that's needed with patients that have an endo stent placed for an aneurysm?
Yeah. So thank you again. As I discussed, these endoleaks can be pretty common complications after endovascular aortic repair. It means that we need to continue evaluating these patients, continue seeing if they have evidence of endoleak, either by duplex ultrasound or repeat CT angiographies. As far as surveillance intervals, I'll be honest, I'm not 100% sure, and I need to look it up. But thank you again for the questions.
Yeah, so it goes to that people like endografts because they're easy to put in. Yeah, you put them in and the next day to go home, as opposed to like you said, a big operation. But when you do have an endograft, you do need close to surveillance, like you said, because there's about 10 to 15% of patients that have endoleaks that need to be treated. So, and this was a good save. This is a very, very good save and a very complex save. And again, it emphasizes the technical skills you need to be a vascular surgery. To do a physician modified graft, you need to be able to sew and make holes in a graft So that's the surgical skills, and then you need to have the endovascular skills to put the graft in. So really, really good job.
Thank you.
I think the other thing this highlights, Loy, and you talk about this with surveillance and follow-up, it's something that is very rewarding as a vascular surgeon that's different than a lot of other surgical specialties, that these patients are our patients for life. We are seeing these patients once a year, twice a year, so you get to know them very well. And it's very rewarding, to fix someone like this and then see him back years later. So yeah, that's something else that I didn't really appreciate until I was a resident, but it's something very unique to vascular surgery for the students.
Okay, and then we'll move on to our third presentation for the night. It is Carl Schofister from Medical College of Wisconsin, and it'll be an aortic bifemoral bypass. What could go wrong?
You need to unmute yourself.
Yeah, thank you. All right, I assume everyone can see my slides. Let me know if you can't, but thank you for the introduction. I'm Carl Schofister. I'm a third-year student at MCW. I want to be a vascular surgeon, and I'll be applying integrated vascular this upcoming cycle. So my talk is titled Aortic Bifem, What Could Go Wrong? Then some history on aortic bifemoral bypass. This has been done for a long time for aortic iliac occlusive disease. And some common indications for this are what you would expect, mainly severe aortic and/or iliac atherosclerosis, or the extreme of this, acute occlusion, as well as the sequela of having really poor distal blood flow. And the gist of the operation you can see in the picture on the right is, restoring blood flow distally through using a bypass, bifurcated graft. And as with most things in that vascular surgery, you must determine if open or endovascular is the right approach. And I did find some recommendations for which one is recommended based off the type of lesion. And then again, if you're considering open surgery, you must consider if the patient is fit to have it. So getting into our case, we had an 83-year-old male, history of aortic bifemoral bypass graft. He came to an outside hospital ED with a day of lower abdominal pain, bloody bowel movement, left groin pain, and a fever up to 103. And he's active and was actually recently out hunting. And some past medical history is kind of what you'd expect, considering he needed the bifem a long time ago. And he had that done in 1983 and had been following with an outside vascular surgeon for known graft degradation, pseudoaneurysms, and bilateral SFA occlusions. And there was a left groin fluid collection that was being followed. However, the vascular surgeon was unsure if this was a seroma or graft degradation. Nonetheless, he believed that this patient would not be a good open candidate and did not see any feasible endovascular options, so he was just monitoring him. So at the outside hospital ED, he was hemodynamically stable, though a little hypertensive. He had an elevated white count and an elevated lactate, and a CT was done, which I'll show on the next slide, which showed an inflammatory process in the left lower quadrant involving the left iliac limb of the graft that was aneurysmal, and the adjacent sigmoid colon. And there was air along the mural thrombus that was consistent with an infected aneurysm. So he was transferred to our ICU with concern for an infected aortic bifem and aortoenteric fistula. So this is the CT scan. I'll show the video in a sec, but on the right is a cut where you can see the pseudoaneurysms, mainly the large one on the left, as well as some on the right there. And you can see air in that mural thrombus, as well as the colon overlying it. We can run through the CT. Here we see the native aorta, calcifications, then you get into the bifem. You see it branched, the two iliac limbs, and then you see these large pseudoaneurysms. So at our hospital, our initial exam showed bilateral bounding pulses in the groins, and the left groin was tender. ID consulted, started on broad spectrum antibiotics. GI scoped him because we were unsure if this bloody bowel movement was from his history of diverticulosis or hemorrhoids, or if this was from an aortoenteric fistula. And they did see a pulsatile intraluminal bulge. Unfortunately, we know the pictures, along with some active purulent drainage. So colorectal surgery was also involved for the involvement of the colon. And he was initially stable, but then he had significant bloody bowel movements. So after extensive discussion, he was taken to the OR, where an XLAP was performed, with lysis of adhesions. Proximal control was obtained below the renal arteries, and the aorta, which we saw in the scan, was pretty calcified between this portion and above the prior anastomosis. And significant adhesions of the bypass graft limbs to the sigmoid colon were seen, and that old graft was just degenerated globally. Distal control is obtained by exposing the bilateral groins and controlling the superficial femoral and the profunda distally. And then we work backwards to expose the femoral pseudoaneurysms. And then a redo aortobifem was done with rifampin soaked Dacron. And then we cut approximately just below the renal arteries, and then an end-to-side proximal anastomosis was performed. And then, as you know, you can imagine with all the calcification in the aorta there, we had to do an endorectomy there. And then the groins were done sequentially, getting into the pseudoaneurysms, clamping the graft. And again, there was so much thrombus and just overall deterioration of the grafts. And then the profundas were used for an end-to-end distal anastomosis. He did require a sigmoid colon resection and had his abdomen temporarily closed. And then an amazing thing to point out was this was an all-woman OR team, which is pretty amazing. And then post-operatively, he was taken back to the OR for closure and colostomy. Cultures grew a bunch of stuff. He was continued on antibiotics, had multiple washouts, and eventually needed groin flaps with plastics. He was discharged to a rehab, but he was just seen a couple months ago, and he's home living independently, still had his ostomy, and was hopeful to start hunting again. And some major learning points. So aortoenteric fistulas can either occur from the native aorta or from a synthetic graft, as these erode into the adjacent enteric system. Nowadays, with all of the procedures that are performed, the second type of synthetic grafts is more common. And this isn't our patient, but I thought it represented it well. As you can see, the aorta forming a fistula between the overlying duodenum here. And these can cause GI bleeding. The classic description is this herald bleeding that can be ominous and escalate pretty quickly. And if patients are hemodynamically unstable, they should go straight to the OR. But if they're stable, you know, you can do a CTA, you can scope them like we did in our case if you're kind of unsure where the bleeding's coming from. And this isn't our patient, but I thought it was a cool picture seeing the graft erode into the duodenum here. And you most commonly see these fistulas between the aorta and the duodenum, like in the past couple of slides, these pictures, around the proximal suture line. We try to prevent this by using an omental patch to protect the duodenum. And in our case, the fistula is actually from the colon to the iliac limb, which is very unusual. And then switching to just abdominal aortic graft infections in general. This is a very serious pathology. I found a stat that it occurs in 1 to 4% of prosthetic grafting procedures. And with a patient like ours that had this chronic infection, or assumed to be chronic infection, it can have this insidious onset where you kind of follow it for years, like with our guy, and then progress pretty rapidly. And I did find some diagnostic guidelines published in the European Journal of Vascular Surgery, the MAGIC guidelines, to aid in diagnosis. Basically, it breaks into 3 categories: 1, clinical and surgical, 2, imaging, and 3, labs. And then using a scoring system tells you the likelihood that this is a graft infection. Sorry, I think it froze a little bit. And traditionally, these have been managed with resection of the infected portion and an extra anatomic bypass, which you can see in the picture here. This is an axillary artery, so you hook up the axillary artery for blood flow and then bypass to the femorals, either from a bifem or a fem to fem. However, superior outcomes have been shown with in situ aortic reconstruction, and total graft explantation with debridement is preferred for these infections. And there are 3 common types that I was able to find. The first one being using a cryopreserved arterial allograft. And this requires having an institutional tissue bank using cadaveric tissue. Or I did find that there is a pre-made product on the market that you can use to do this reconstruction. Another way to do this is using the patient's own femoral vein and grafting that. This is called the NACE procedure, and you can hook it up in any way that you want, depending on the patient's pathologies and anatomy, which you can see here. And then the last option is what we did at our institution was using an antimicrobial treated synthetic graft. So this can either be antibiotic soaked or silver coated. And this is a picture showing a rifampin soaked graft on the left, and then the NACE procedure in the middle, and then the cryopreserve on the right. And this is actually from a talk presented at MVSS in 2011. So the cryopreserved allografts and the femoral vein grafts for the NACE procedures, I did find have superior patency and reinfection rates. However, a big limitation is access in urgent situations, especially if you're at a place that doesn't have this institutional bank or access to that pre-made commercial product, which I can assume is pretty expensive. And the rifampin soaked ones, the limitations of that, I did find were higher reinfection rates and then emergence of rifampin resistant bugs. But again, these can be more an off-the-shelf solution. And then endovascular options for aortic graft infections can be used as a bridge to definitive care or as a palliative approach if the patient's not suited to have open surgery. And then conservative management with prolonged antibiotics with washout can be done as a bridge to elective surgery or a palliative treatment. And then if you have sorry, I think someone's unmuted, but I can continue. Surgery is first line if an aortic enteric fistula is present. And then conclusions, these are very serious pathologies, and monitoring a patient both clinically and radiographically when warranted is crucial. I mean, ideally, we prevent aortic graft infections in the fistulas, but there are multiple surgical options available to treat. And there is a lot of literature supporting the different methods for open reconstruction, especially with the infected aortic endograft. And I did find that there is variation in practice between different institutions. And these are my references. And I'd like to thank Dr. Rothstein for her help, and we can take any questions.
I guess I think one question, and I'm glad that you presented a lot of options for, other ways you could do this reconstruction, because there are a lot of options. Thinking about doing this in the setting of an aortoenteric fistula, what are your thoughts on doing the various different kinds of reconstructions, knowing, what your bacterial kind of populations are expecting to have in your infection?
Yeah, that's a great point. I feel like I would lean more towards the antibiotic soaked, considering it's very, dirty, and there are a lot of bacteria that we ended up growing from the cultures, and it was in the blood. Yeah, I guess I'd lean to that if that's possible. I mean, especially not doing the extra anatomic, knowing that like the groins were dirty too, and not wanting to go that route. I guess Dr. Rothstein, you can add anything too. But
I was going to say, Carl, you did a great job with that. It's obviously a very complex case. We are very much a make it orange institution. And, some of the things that, and Carl kind of summarized this very nicely, the NACE procedure I think is a great option. You got to have a small army of people to do that in a timely fashion. And, this was something we did. It was like the Friday after Thanksgiving, starting at about 6 p.m. because that's when he started bleeding. So I think if you can kind of control these patients and do this in the light of day, some of those other options are really great. We do not have cryopreserved graft readily available at our institution. I don't know, Captain Loay, I don't know what you guys all have, or Ashley, but we're kind of a painted orange institution. And again, extra anatomic for this gentleman, his groins were going to be gross too. And there was nothing that was going to keep us out of his abdomen. So, and Carl didn't go into this, but for the students, you can also do this staged. So say it was just an aortoenteric fistula where all the infection is in the abdomen, you could do an extra anatomic bypass first, as one operation, then bring them back a day or so later, and then do the explantation as a staged operation is another option. For this guy, it was kind of an all or nothing given the extent of everything.
Yeah, I mean, I think we are lucky to have cryo at our institution. However, I don't like it very much either.
I've only ever explanted it.
It falls apart really easily. If you do use cryopreserved aortic graft, I find that it dissects very easily. You get these dissection flaps that form within it, and so I think it's not ideal either. So I kind of hate to use it, but do use it in certain settings.
we actually have the opposite. We use Choreograph all the time and we love it. So we're a Choreograph institution, even though it's really expensive. So Carl, you asked how much it costs. It costs about $10,000 for a Choreograph to when you place it in. So it's not cheap. It's still, when you look at what other, we could talk about the toys we play with as vascular surgeons. And Catherine and Abby and Ashley know this. When we put an endograft in, a simple endograft, like the physician modified endograft that Jack just talked about, that probably costs about $15,000 to $30,000 roughly, just the components of it. And that's not talking about the OR time and everything else. So it is we're privileged to be able to do things like that in vascular surgery and have the support of the insurance companies and the institutions for us to have these expensive toys to play with. Yeah, and
there was one question in the chat. I think Carl, you answered most, but the original graft was a Dacron graft. It was 40 years old, so this is actually one of the longest standing aortobipham grafts I've ever seen. I was doing this case with Kelly Brown, one of my women senior partners, who was former president of the MVSS, and she has never seen anything like this. And when your senior partner is saying, "I've never seen anything like this," it's kind of an interesting case. So. And then, yeah, again, for the students too, the thing that Carl nicely pointed out is we had an all-female team. It was 2 female vascular attendings, a female vascular fellow, a female colorectal surgeon, and a female resident, and our anesthesiologist was female too. So shout out to all the women who want to go into vascular too. So we will keep moving then with our final presentation from Washington University School of Medicine. We have Carolyn Carper and Braden Benedict presenting a case about a complicated type B aortic dissection.
Hi, everyone. Thanks for coming in and listening and giving us the opportunity to present this case. I feel like we've heard lots of really interesting success stories in vascular surgery today and lots of just really interesting things. And this case kind of has a sadder tone, maybe not one of the best outcomes, but we thought it would be important to talk through because they're big, or Dr. Holzem taught us about some of the big learning points there. I guess for a little bit more background on Braden and I, we're second-year medical students. We are in our surgery clerkship right now and just finished our rotation with vascular, which is how we connected with Dr. Holzem. So for this case, we'll jump into it. We have a 59-year-old man who presents to the ED with his chief complaint of bilateral lower extremity pain and weakness. As far as some relevant history goes, he had this acute onset of pain early in the morning down both of his legs. He also had some weakness and some numbness. He described some like pins and needles and paresthesias there. He had also just a few days previous been to the emergency room for flank and upper abdominal pain, which wasn't worked up for much. He has no history of claudication or any other vascular disease, and he was also recently diagnosed with community-acquired pneumonia and was taking antibiotics for those. As far as some relevant past medical history, he has a history of polysubstance use disorder with recent cocaine use the day prior. He also has a history of hypertension and sciatica. On exam, this gentleman was ill-appearing. He had non-palpable femoral and pedal pulses. His lower extremities were both cold, and there was delayed capillary refill under the level of the umbilicus. His vitals were also concerning. He had a blood pressure of 215/48, heart rate of 69. But he was still satting well. As far as relevant labs, his lactate was significantly elevated. His creatinine was significantly elevated from his baseline, and his cardiac markers were very elevated. He was also found to be anemic. So given this information, he was sent in for a CTA, which we'll play here, and we'll have relevant images of the key pathologies in following slides. Here you can kind of see the dissection. And then the blood vessels kind of disappear and you don't really see anything coming up. So we'll get into that in a second. So they found that it was a type B aortic dissection. It started in zone 5. And the dissection, as you can see here, extended into the celiac trunk, but the celiac trunk was still patent, and the liver and other organs seemed to be fine. The other finding was that the SMA was occluded. This little stump here shows where the SMA should be branching off of to supply the intestines and organs, but here it's fully occluded by the dissection flap. A few other things that we found on the CTA for the next slide was that the dissection flap had fully occluded the left renal artery. As you can see, the left kidney here is not well perfused as compared to the right, and you can see how the right is still patent right there. And the last relevant finding is this slide. You should be seeing iliac arteries, and I think their shadows are right here, but they're fully occluded because the dissection flap had extended it into both iliac arteries. So as far as the overall assessment and plan for this case, overall assessment, it was a 59-year-old man with lower extremity pain, paresthesias, weakness, and coldness, consistent with acute limb ischemia. He was found to have a complicated type B aortic dissection starting in zone 5, so around here in the aorta, and including the SMA, left renal artery, and bilateral iliac arteries. So as far as a few definitions and teaching points here, a complicated type B aortic dissection is different from an uncomplicated type B aortic dissection in that it causes malperfusion or organ ischemia. So because this was causing ischemia to his legs and his bowels, it was a complicated dissection. So as far as the surgery objectives, the surgeon chose to do a branch or limb first approach and restore flow to the vital organs by opening up the occluded SMA. I think the big concern here was that this gentleman would pass from mesenteric ischemia before they would be able to resolve or take care of the dissection. So that was the main priority going into the surgery. The second thing that they also prioritized was restoring flow to the legs with an axillary bilateral femoral bypass. So for this procedure, the first stage was restoring flow to the SMA. So they did a exploratory laparotomy and exposed the SMA. They opened up the SMA and performed a thrombectomy. Then they proceeded to perform a ROMS of the proximal SMA, and then from there shot a few images and completed an aortogram and SMA angiogram. And they also completed an intravascular vascular ultrasound of the aorta and proximal SMA just to make sure everything looked all right there. The second stage, after they were able to confirm flow through the SMA, they proceeded with the right axillary to bifemoral artery bypass using a 6mm ringed PTFE. And then, since this gentleman had acute limb ischemia for I think at this point it was around 6 to 7 hours, they also performed a bilateral lower leg for compartment fasciotomy for compartment syndrome. So following the surgery, I will hand this presentation over to Braden to talk about the post-op course and next steps.
Yeah, hi. So after this initial operation, the patient had regained flow to his extremities, but his lactate did still continue to climb, and his state further deteriorated with evidence of mesenteric ischemia. CT showed that the SMA stent, which had been placed, had actually been dislodged and was now sitting in the aorta, possibly held in place by the dissection flap, which was still present since that had not been repaired. So we think what happened was it was basically hanging too far out into the aorta, and then essentially did a 180 and flipped out with the side that was proximal now distal in the aorta. So obviously this is a big problem. This is SMA is no longer being perfused. So upon return to the OR, the groins were reopened. The fem-fem bypass limbs were removed in order to be able to directly visualize and access the true lumen. And fluoroscopy, as you can see here, demonstrated that free-floating stent, as you can kind of faintly see there in the aorta, as well as continued occlusion due to the dissection. To remove the stent, a wire was inserted through the left femoral artery, through the middle of the stent, which is confirmed with this intravascular ultrasound, which you can see here. You can see the stent present right there, as well as the dissection flap. And so this is kind of where this gets pretty interesting. So a balloon and gooseneck snare were introduced through the femoral artery in order to basically get the stent out. So the balloon was inflated to capture the stent, and then the snare was cinched down across both the stent and balloon. And here you can see the process of removing that kind of contraption, as well as an image of what this looked like when it was taken out. And kind of one of the interesting points is to do all this, the snare had to actually be loaded on the balloon shaft ahead of time, and have it all inserted to be able to capture and remove this stent that was floating around in the aorta. So after this was removed, the aortic dissection was repaired with multiple stent grafts in the thoracic aorta to fully tack down the dissection flap. The dissection stents were extended down through the aorta, and the SMA was again stented, as was the right renal artery. And you can, if it plays, should be able to see that the SMA is now finally being perfused again. And then just kind of last thing, since that fem-fem bypass had already been removed and there was already good flow through the both iliacs, that ax-fem bypass was also disconnected and ligated. Unfortunately, despite, now having good perfusion of all organs, the patient continued to decline. While during the previous surgery, the small bowel had shown some signs of ischemia, by 2 days after the second surgery, this had progressed to extensive necrosis, and the patient ended up dying 2 weeks after his initial presentation. So kind of to go over some, concluding points here, type B aortic dissections make up around a third of all aortic dissections and have, while not as high of a mortality rate as type A, still have an in-hospital mortality rate of around 13%. And then this is a small study of patients that's been published looking at patients with lower extremity malperfusion and type B aortic dissections. And they found that proximal aortic dissection treatment, what was ultimately done in that second surgery, was associated with lower mortality and reoperation rates compared to a limb-first approach, which was what was really kind of done in that first surgery. And dealing with that, the aortic dissection ultimately resulted in 70% of patients having restoration of that lower extremity malperfusion. So this case in the unfortunately poor outcome for this patient emphasizes the importance of treating that proximal dissection flap first, which is kind of the mainstay of therapy for this. So thank you, and yeah, again, happy to take any questions on this.
Thank you, Brandon and Kelly. It was a very good presentation of a very complex disease process. At Barnes, do all type B dissections get admitted to the vascular surgery service primarily, or are they admitted to medicine and vascular surgery consulted?
They're generally admitted to our service, so
yeah, I think this case emphasizes why they need to be admitted. So the nice thing about vascular surgery, there are certain disease processes that we take care of, right? Aneurysms, peripheral arterial disease, venous disease, and one of them is dissections. And this emphasizes why we take care of dissection, because most of them, like you said, can be treated medically, but you have 10% that present like this, and they're really complex to take care of, and it's not a simple solution. And you've shown a lot of tools that vascular surgeons have that can take care of it.
Yeah, this has become the case that I use to teach all the trainees about, I think we just don't see enough complicated type B dissections. We see a lot of complicated type A dissections because that's, really what they are. But, so I think we forget that, we should use similar principles to treat the type B dissections as we do the type A, where, you're trying to, if you attack that flap, you don't know what kind of reperfusion you're going to have and what you're going to restore. So.
Yeah. And what's really interesting, a lot of people don't understand dissection the same way we do, and they fear them. When I first started about 10, 15 years ago, the type B dissections were admitted to medicine, and then you would have 10% of these patients that would get into a complication, and they didn't know how to deal with them. So again, it emphasizes taking care of the disease process. This is what vascular surgeons do. We take care of the disease process, and we do it with medicine. We do it with endovascular. We do it with open. And Catherine and her students showed that they took care of the blood pressure. They took care of an open operation, they took care of endovascular operation, which is all the tools that vascular surgeon has that not everybody, not any other specialty that I know of can offer all that. Sweet.
Well, it looks like we're getting towards the end. I think we had 2 announcements. Angela, can you put up the last page for us, or was there any other questions that we needed to address?
The slide?
Yeah.
Sure,
With
hold
the
on.
dates for things. I just don't know the dates.
Yep.
Sorry.
All right, 1 second.
Thank you for all the interesting presentations and everyone's time tonight. And then we have the 2 announcements. On August 20th, we'll have the Introduction to Vascular Surgery event and the virtual residency affair. And then Friday, we're going to have the live surgical sessions and mentorship program at Midwest in Chicago. And thank you for your time.
Yeah, and please, the people who attended, I think we do have sponsorships and we do have funding for medical students that want to attend. So please email us. There's a link on the website to apply for scholarships. Please use that. And we'd love to see you in our annual meeting in Chicago. It's a lot of fun. Thank you, everybody.
Thanks all.